Hello, you're welcome to Medical Sciences Made Easy by Naphtali Muhumuza. And in this session, we want to look at the interpretation of renal function tests, or what we call kidney function tests. We want to see how you can use the parameters under renal function test to diagnose or to come up with the diagnosis of the patient in our hospital setting. And the tests which are done under renal function test, majorly and many labs, they are doing creatinine, serum creatinine, and urea. And sometimes doctors can be interested in the blood urea nitrogen, which we saw in previous video on how to calculate. That whenever you have urea concentration, you can use it to calculate burn. Whereby we say the blood urea nitrogen is equal to 28 out of 60 times the concentration of urea. So these are the parameters we can do, but the other non-protein nitrogen compounds, which are produced as waste products of metabolism, we have ammonia and uric acid. But many times ammonia is not done. We do measure creatinine, urea, and uric acid. But the uric acid measure, they don't put it under renal function test, but it's part of the renal function test. So we shall talk about it in details, and we shall also see microalbumin, which is a new test that has come on board, which we can call microalbumin creatinine ratio, which we can use to diagnose kidney function. Even before you get signs and symptoms, you can be able to know that you are at risk of developing kidney diseases using microalbumin creatinine ratio. And then lastly, it is electrolytes, but in this video we shall not talk about electrolytes. We shall talk about interpretation of electrolytes in the next video. So in this, we are going to focus on creatinine, urea, then uric acid, and microalbumin. So under creatinine, if I have results of creatinine, serum creatinine, this one we normally say it is the best marker, or it is the best marker for renal. Why? Because it is not majorly affected by age, it is not affected by diet, and it is not reabsorbed, not secreted. So that's why it becomes a good marker for determining functioning of the kidney. And we normally say that these renal function tests are done to diagnose kidney diseases. That is, it can be nephrotic syndrome, it can be glomerulonephritis, it can be pyelonephritis, that is infection of the kidney, and we can see it under kidney also being diagnosed kidney stones, then any obstruction that causes urine outflow. So even we can do renal function tests to monitor people on treatment of certain diseases, like people who are on antiretroviral therapy. We do renal function to monitor, and also monitoring on people who are on treatment of diabetes and hypertension. So these renal function tests, especially the creatinine, which is the best marker for kidney functioning, we said it is produced by it is from the muscles, or the myocytes are the one that store this creatinine. So we saw that muscle mass is affecting creatinine levels, where we saw it is higher in male than in female, because the female has muscle mass compared to male. And we saw how to determine it by Jeffers-Roth's method, where we use the picric acid. So if you haven't watched on the video on determination of creatinine, please go back and watch about it. And this creatinine, its reference range in male, it is 0.7 to 1.3 milligrams per deciliter, whereas in female, it is 0.6 to 1.1 milligrams per deciliter. This is the reference range. And whenever you do creatinine, serum creatinine levels, and you find it is elevated, elevation, it means it should be, for you to say someone who has kidney failure, should be 3 times the upper limit. So if it is 1.3, to declare someone with renal failure, it should be at least 1.3 times 3, that is like 2.9 to 3. That's when you can say someone has kidney failure. So it should be 3 times the upper limit. And when you find it is 3 times or 2 times the upper limit, increase in creatinine, when you find that is increase in creatinine levels, you can suspect conditions like there is what we call cardiac congestive heart failure. Congestive heart failure, which can lead to decreased blood flow to the kidney. That is, so we see majorly hypoperfusion. You can say hypoperfusion. And this type of perfusion is reduced blood flow to the kidney, which can be caused by congestive heart failure, can be hypotension, it can be shock, it can be reduced blood volume, what we call hypovolemia. It can be dehydration. So these conditions, they lead to elevated creatinine levels. And these are pre-renal causes. So here the kidney is normal, but the blood flow to the kidney is reduced. So that's why we call it pre-renal. So this is the pre-renal cause. This is, we can put them under pre-renal causes of elevated creatinine. And other causes, we can see kidney diseases, like acute kidney injury. We can see chronic, can see it elevated in chronic kidney injury or failure. We see them elevated under kidney diseases like glomerulonephritis, You can see them under acute tubular necrosis, whereby the cells of the kidney are undergoing necrosis. You can see it elevated. You can see this elevated in kidney stones, and it can also be elevated in obstruction. And this obstruction is not part of the kidney diseases, so this one can be post-renal. These ones are post-renal causes, whereby post-renal, we see obstruction. They obstruct the urine flow, obstruction of the urine flow, which can be caused either by prostatic hyperplasia. Can do that. We see it in the urinary strictures, rupture of the urinary bladder, You can see it elevated, even urinary schistosomiasis. So any condition that can block the urine flow or that can block the urethra, we can find creatinine elevated. And these are the same causes of both creatinine and urea, whereby whenever you have a condition whereby both creatinine and urea plus ammonia are elevated, this condition is known as azotemia. So azotemia is increase in levels of non-protein nitrogen compounds. So it is a general term. So when we find creatinine is elevated, we find urea is elevated. We find even ammonia is elevated. That is what we call azotemia. And there are different types of azotemia. We have pre-renal azotemia, renal azotemia, and post-renal azotemia. Whereby pre-renal, the cause is outside the kidney. Either the blood flow to the kidney is obstructed. That is what we call pre-renal. Then renal is whereby the problem is with the kidney. That is due to kidney diseases. And then the post-renal is the one that obstructs the urinary outflow. So that is what we call azotemia. So these ones is the pre-renal azotemia. This can also be the causes of renal azotemia, whereby both urea and creatinine, they are elevated. We see all of them in these kidney diseases, including nephrotic syndrome and pyelonephritis. Here you never put pyelonephritis. We can also see nephrotic syndrome, where we find proteins in urine. Nephrotic syndrome. So all these diseases are what we call renal azotemia, or causes of elevated both creatinine and urea, or blood urea nitrogen. And then these are post-renal causes. These ones whereby there is obstruction of the urinary flow. Yes, the kidney is functioning normally, but as we go to the part of excreting urine via urethra, it is blocked. So if this is the urinary bladder, this urinary bladder is leading into what we call the urethra. This is the urethra, and this is the bladder. We see anything that blocks the urethra being a post-renal cause of azotemia. So we find them elevated in post-renal, in renal, and pre-renal azotemia. So that is what we can talk about. But briefly, as we want to talk, there are other causes of increased urea or blood urea nitrogen, but when they do not affect the creatinine. And also there are other causes of creatinine whereby it is high and they do not affect urea. So we can see that another thing we can talk about is that creatinine can be elevated also in muscle dystrophy. Muscle dystrophy. Any condition that causes muscle dystrophy, we find the creatinine is elevated. And also we see elevated in strenuous exercise. People who do strenuous exercises, like the athletes, the strenuous exercise. So people who do much work involving muscle, we can see them also being elevated. And we see creatinine, causes of low creatinine, we see creatinine is decreased and be decreased majorly in muscle wasting diseases. Muscle wasting diseases. Whenever that any disease that causes emaciation can cause low protein. So any low creatinine. So muscle wasting diseases, we can see creatinine being high. So that is what can cause, being low. That is what can cause low serum creatinine levels. Muscle wasting diseases can cause. And sometimes this can also be even pregnancy. Pregnancy lowers creatinine levels. So pregnancy, and sometimes liver disease. Liver disease, why liver disease? Is that this creatinine is manufactured in the liver. The first part is in the kidney, then it is transported to the liver, where in the liver there is completion of the manufacture of creatinine. So someone with a severe liver disease might have low creatinine levels. So these are some of the conditions which can lower creatinine levels. So after looking at the creatinine levels, which is the best marker? So you cannot base on one parameter to decide the cause of kidney injury. You always have to ensure you interpret both creatinine and urea to come up with the best results. So the next thing I want to talk about in this position is urea. Talk about urea. By this urea, there is also another video which we looked at how we determine urea by Barthold's, by enzymatic method, and by diacetyl monoxime method. There are three methods we use to determine urea. And whenever there is elevated urea, we call it uremia. So increase in urea, by the reference range of this urea is 15 to 45 milligrams per deciliter. This is the reference range, and increase in urea, when it is only urea elevated, we call it uremia. We saw when both creatinine and urea are high, it is azotemia. But when only urea is elevated, that is uremia. And there are many causes of uremia, whereby we have pre-renal causes, we have renal causes, and we have post-renal. So sometimes in an exam, I can ask you to outline any 4 causes of pre-renal, or I can ask you to outline any 5 causes of renal azotemia or renal or uremia. So you have to be able to distinguish. Even in multiple choice questions, I can easily ask you the following are causes of post-renal azotemia except. So you should be able to know which ones are pre-renal, which ones are renal, and which ones are post-renal. And part of the pre-renal causes of uremia is increased protein catabolism, As we saw previously, urea cycle. Urea, which is being part of the deaminated amino acids, which are part of the protein. So whenever there is increased catabolism of proteins in the liver, we see urea going high when creatinine is normal. We can also see it in GIT breeding. GIT breeding can also be part cause of elevated urea, what we are calling uremia. We can see it in these infections, particularly malaria and typhoid. Malaria and typhoid can also cause uremia. Then we see also hypoperfusion, which we saw previously, whereby we saw different causes of hypoperfusion. Hypoperfusion is reduced blood flow to the glomerulus. And when you are getting raw blood being filtered, meaning low waste products of metabolism are excreted. So we are seeing hypoperfusion, which we saw it was being caused by conditions like congestive heart failure. We saw hypotension. We saw hypovolemia, that is reduced blood. We saw shock and dehydration causing hypoperfusion or reduced blood flow to the kidney. So these are the major causes. And even another one which can lead to uremia is increased protein dietary intake, increased protein diet. So when you are taking diet rich in proteins, because the more the proteins, the more the urea cycle will happen to produce more of the urea. So when you are taking food rich in proteins, it can also be part of pre-renal causes. That's why we say urea is not a best marker for detecting kidney function. Why many conditions can cause it to be elevated. But we saw creatinine, there are few conditions, only hypoperfusion. But we are seeing creatinine of urea being affected by diet, by age, by GIT breeding, infections, and diet of the protein. That's why it is not a best marker. Then these are pre-renal. The kidney is doing well, but the causes is outside the renal. Then the renal causes, there are those diseases, kidney diseases. Kidney diseases, which we have outlined, like it can be acute kidney injury, it can be chronic kidney injury. Acute means the cells of the kidney are fading within hours. Within 1 to 2 hours, the kidney shuts down. But chronic, this is whereby the kidney cells are destroyed progressively within a couple of years. That is what we call chronic. Then we are talking about glomerulonephritis. Glomerulonephritis, which is inflammation of the glomerulus. That when the glomerulus inflames, it can even start allowing blood cells to pass through, and it can also allow proteins. So this one can result into glomerulonephritis. Glomerulonephritis can result into nephrotic syndrome, whereby we find proteins in urine. We can see also diseases like pyelonephritis, where you have inflammation of the glomerulus due to the bacterial infection. So they can lead to that. what we call PID, pelvic inflammatory disease. This one is PID, pelvic inflammatory disease. Then we have seen kidney stones also being part of the renal. And then also we saw acute tubular necrosis. And this acute tubular necrosis is the one that can result into acute kidney injury. So these are the renal causes of elevated urea. Then the postrenal, they still remain the same, whereby postrenal is any disease that causes obstruction of the urinary flow, whereby we saw rupture of the urinary bladder. Rupture of the urinary bladder, we can see urinary cystosomiasis. Cystosomiasis, and especially cystosoma hematobium. That this cystosoma hematobium affects the urinary system and it can block the urethra, leading to elevated urea. We can see it in urinary strictures, whereby urinary strictures, this is that when you have an infection, the infection after healing, it leaves a scar. And when this is the urethra, and these scars continue to enlarge, and they continue to enlarge, and they can block the urinary flow. That now urine will not be able to flow to be excreted. That is what we call urinary strictures. And then we can also see it in the prostate hyperplasia or prostate cancer. It can be prostate hyperplasia, that is enlargement of the prostate, or we can see it in prostate cancer. So these are post-renal causes of uremia, whereby we said whenever only urea is elevated, the cause might be the kidney is doing well, but the cause might be post-renal or pre-renal. But whenever you do both, and you find both creatinine and urea they are high, it suggests more of the renal causes. But if one is elevated, then it can be post-renal or pre-renal or post-renal. But when all of them, so we find in the renal, we find both creatinine and urea, they are elevated. That is what can make us suspect the renal cause. But whenever we do what we call urea creatinine ratio, or what we call burn creatinine ratio, and we find this ratio is greater than 1. If it is greater than 1, we can suspect pre-renal or post-renal causes. But majorly pre-renal. So pre-renal we find urea stroke creatinine ratio greater than 1. So we can always do that to determine if the cause of elevated urea. This one means urea is so high, creatinine is somehow low or normal. And it means it is much of the pre-renal causes. So this is what we can talk about briefly on the azotemia, or that is elevation of creatinine and elevation of urea. And what causes the same causes of low creatinine, we can see some also other causes leading to low urea. So we see conditions that lead to low urea: decrease in urea concentration or blood urea concentration. We see it majorly in HIV, chronic diseases like HIV, stroke, AIDS. We see it in chronic liver disease because urea cycle occurs in the liver. So whenever there is liver disease, means there is no production of urea. We can see this one, we saw this one in pregnancy. And we can see pregnancy, liver disease, and we can also see it in malnutrition. Malnutrition, whenever you are taking food without protein for so long, without protein, we cannot have urea. So malnutrition, especially taking food lacking proteins, can also result into reduced urea levels. So this is what we can talk about under creatinine and urea. So the next parameter I wanted to go to is uric, and before uric acid, I can talk about microalbumin. Microalbumin. And sometimes we call it microalbumin creatinine ratio, or we can even call it albumin creatinine ratio. This microalbumin, the word micro means small or traces of proteins found in urine. And we said this is when you are determining microalbumin, it is the one that detects, it can detect kidney disease. It detects kidney diseases very early, even before the signs and symptoms. You don't have any sign and symptom of edema, you don't have any sign, but you are at risk of developing the kidney disease. So we can use microalbumin to detect, or for early detection, or to know if you are at risk of soon developing kidney injury. And this microalbumin is the best marker. It is the best marker than creatinine, than urea, detecting early, or detecting if you are at a risk of developing kidney diseases. So microalbumin, that's why I'm urging laboratories and medical doctors to always request for microalbumin, especially to people who are on risk. The people who are at the risk of developing kidney diseases include diabetic patients, people who are diabetic, people with diabetes, people with hypertension. So someone with diabetes and hypertension, these are at a high risk. And we should always monitor their kidney function test every year. Every day they have to first always check for the functioning of their kidney. And we should always include microalbumin, creatinine ratio, to rule out any RF cause, or to see if someone is at a risk of developing the kidney disease. That is the function of microalbumin. And even we can also do it to people who are greater than 40 years, because they are also at a risk of developing. You can also do it on obese patients. When you are obese, you are above 40, you are required also to perform this microalbumin creatinine ratio. That when we find it is elevated in the blood, that is greater than 29. When we find, because the reference range of microalbumin should be less than 29 grams per liter. So whenever I do it and I find it is greater than 29 grams per liter, that is increased microalbumin levels, and that is what we are calling that you are at a risk. So if you are a diabetic patient, you are hypertensive, you have hypertension, you are above 40, you are obese, and we find your microalbumin is above 29 without any signs and symptoms, it can tell us you are at a risk soon developing kidney disease. So we can even treat you before to prevent, because the earlier the better. Early diagnosis leads to complete healing. So we can always use it as a checkup. So I urge medical, this is what has come in, and let us embrace this technology of microalbumin. And lastly, we can talk about is uric acid. Talk about uric acid. Lastly, it is uric acid. This uric acid, it is a component which is derived from purines. We see it being derived from purines, that is guanine and adenosine. These are complementary base pairs in DNA or RNA. So we are saying that this uric acid is derived from purines, that is guanine and adenosine. These guys undergo metabolism to produce uric acid. So meaning, since it is being derived from purines in muscles, and that is the guanine and adenosine, we see it increased intake of meat, especially red meat, can be at a risk of increasing levels of uric acid, what we call hyperuricemia. Hyperuricemia, this hyperuricemia, it leads to accumulation of urate crystals. You find urate crystals in urine. These urate crystals accumulate in the kidney. And when these urate crystals accumulate in the kidney, they can even go to the joints. They can be accumulated in the joints, especially the joints of the big, on the foot, on the toes, and then in the knee joint, and this can result in what we call gout. So increased uric level is what we call hyperuricemia. Leads to accumulation of urate crystals in the joints, leading to what we call gout. And gout, this is characterized by painful joints. You find that they are inflamed, they are swelling with pain. That is what we call gout. So whenever you have swollen joints, especially on the feet of the leg, and you feel much pain and you have been taking much of meat and even sometimes much of the beer, you can always go and test for uric levels. The reference range of uric levels is, for female, it should be between 3.0 to 6.0 milligrams per deciliter. Then for male, should be 3.0 to 7 milligrams per deciliter. So whenever you find greater than 6, greater than 7, is what we are calling hyperuricemia. And the causes we have seen of hyperuricemia is increased intake of red meat. Whenever you have been taking red meat, increased intake of red meat, you are at risk of developing hyperuricemia. You have been taking much of the beer. These alcoholic drinks can lead to this. And also it can be reverted in the renal, what we call renal diseases. The cost is also excreted via the urine. So we can see what we call kidney diseases also causing elevated of uric acid. So whenever you have renal failure, it can also lead to hyperuricemia. So renal diseases, taking in much intake of beer, much intake of red meat, can result into hyperuricemia. And increased purine metabolism. Whenever you have increased purine metabolism, it can also lead to hyperuricemia. So these are the causes we can look at under uric acid. And this uric acid is being determined in the laboratory by uricase method. And that uricase method, we shall look at it in the other next videos. Thank you so much for listening. Please always remember to subscribe. Always remember to subscribe, share your comments, and always like the video that we may continue to grow. Thank you so much.